We are online.
Good evening, everyone. I welcome you all to iFocus Online. Today, we have lecture number 13 in the Refractive Surgery module on the topic Pre-LASIK Workup, Calibration, and Laser Programming. It is being presented by Dr. Kiran Kirtani. Our moderator for today is Dr. Lakshay Dudeja. Sir did his MBBS from Maulana Azad Medical College and MS in Ophthalmology from Kasturba Medical College. Sir did his fellowship at Irvine Eye Hospital, followed by fellowship in cornea and microsurgery at Irvine Eye Hospital. Sir also did his ICO fellowship at Kellogg Eye Center, Michigan, and worked as a medical officer at Irvine Eye Hospital. Sir also worked as an associate consultant in Center for Sight, New Delhi, and now Sir has his own clinic, Dudeja Eye and ENT Center at Sonipat. Welcome, Sir.
Thank you, Navneet. Thank you.
I would also like to welcome our chairperson for today, Dr. Paresh Vaidya. Sir did his MBBS, DO and MS from Government Medical College, Surat. Sir is currently a senior consultant at Center for Sight, Surat. He has an experience of more than 25 years in anterior segment, cataract, refractive surgery, and comprehensive ophthalmology. Sir has served as a medical director of South Gujarat at Center for Sight Group and president of Surat Medical Consultants Association, president of Rotary Club. Sir has performed more than 60,000 phaco cataract surgeries, over 100 femto cataract surgeries, and more than 21,000 LASIK surgeries, 100 femto bladeless LASIK surgeries, over 210 ICL implantations, 100 C3R surgeries, 20 smile refractive surgeries, and 4,000 free cataract surgeries. And Sir routinely performs premium IOLs like multifocals, torics, and trifocals. Sir has delivered many talks and lectures at national and international conferences and took part as a panelist in Symposium of Bosch and Loeb in Ahmedabad 2018. Sir has conducted various workshops for ICL surgery and making LASIK flap. He has received many awards from institution and but Mentor Award 2 times is remarkable. Sir has also received gold medal by Lok Sabha Speaker Shri Om Birla Ji in IIRSI conference in Delhi held in the year 2023. I welcome you, sir.
Good evening, Dr. Dudeja, and thank you very much, Dr. Navneet.
Lastly, I would like to welcome the speaker for today, Dr. Kiran Kirtani. Ma'am has done her MBBS from BJ Medical College in Ahmedabad, and ma'am is a MS with gold medal from MNJ Eye Institute, Civil Hospital, Ahmedabad. Ma'am did her senior residency from DDU Hospital in New Delhi, and currently she's a senior consultant at Center for Sight, New Delhi. Ma'am is a trained and certified femtocataract surgeon and refractive surgeon. She's also organizing secretary of a prestigious PG training program iFocus and an organizing secretary of IIRSI. Ma'am is faculty in iFocus, IIRSI, and various other conferences, and she has authored various book chapters and publications in index journals. I welcome you, ma'am. Over to you, ma'am, for the lecture.
Thank you,
Thank you
Navneet.
very much. Thank you very much for the kind introduction. And it's an honor. First of all, I would like to thank Dr. Maipal sir, Dr. Ritika ma'am, Santosh sir, and Dr. Tulika for this opportunity. This is a tough topic. I hope my seniors will be able to guide me through the topic so that it is more lucid for all of you to understand. And my colleagues, Dr. Lakshay and Dr. Navneet, will also help me in making you understand this topic, not only from the point of view of examinations, but also from point of view of practical usage in daily life. So I'll be sharing my slides now. Uh, please confirm that my slides are visible.
Yeah, it's visible.
So is this much amount of this thing, is it okay?
Yes, ma'am, it's okay.
Right. So my topic is LASIK pre-op workup and LASIK pre-programming and calibration. So the focus of my topic is to make you understand as to it's basically compendiumizing whatever you have learned so far, and it is also trying to introduce you to your lectures which are upcoming in times to come. So not only in this lecture we'll try to sum up whatever you have studied so far in terms of the preoperative conditions or preoperative history taking or topography findings which you are supposed to know for practical purpose and also for your exam point of view. We'll also be initiating you to various machines which are used for laser systems, which will be detailed upon by further speakers as their lectures come. So preoperative workup and decision making in LASIK involves, first of all, the workup involves decision making. On the day of surgery, we need a final workup in the form of a manifest refraction, which we are finally going to correct, and a formatting and planning of the surgical treatment on various machines. So we need pre-laser settings. And while we are doing that, we have to calibrate our machines to work to the best of their capacities under the circumstances. First of all, coming to the decision making, because this is the hardest part. For rest of the things, you do get technical and engineer support, but this is where the surgeon has to really put his brain and mind and heart into it, because your surgery is being performed on absolutely virgin eyes, and one mistake from your end can ruin a patient's life. So please make sure that you try to learn this topic if you are interested in refractive surgery for future by heart, so that you don't forget even a single point which can cause you troubles during your surgery. So dilemmas involve, is the patient first of all suitable for any refractive surgery? And if at all the patient is suitable, then what is the kind of surgery which is best for your patient? Though we try to have a quest for an ideal candidate in the form of somebody who's an 18-year-old having a stable refraction, non-pregnant, non-nursing, having no systemic or autoimmune diseases, adequately counseled, but this is just the ideal case scenario. There are lots of ifs and buts which keep on coming on your way, and you have to keep your eyes and ears open for that. So, first of all, let's try and understand the clinical history. And the most relevant points that I feel that we tend to miss are something that I would like to highlight. So, minimum age guidelines, we all know, is 18. But for phakic IOL, the minimum age guideline is 21 years. So, don't forget that. Personality type, if a patient is extremely anxious or calm, you have to think that the patient can turn uncooperative during surgery. In the social and personal history, you also need to understand, are there any professional reasons which are goading this patient to undergo a surgery? So, a patient who wants to go for contact sports or who has to appear for Army or Air Force interviews may require different types of refractive procedure. In past ocular history disorders, you have to think of specifically ocular herpes, because there can be a risk of postoperative recurrence of the hepatic keratitis. You have to look for dystrophies or any epithelial basement membrane disorders. Such disorders during the surgery can cause a lot of epithelial defects and erosions. And later on, also, the patient can land up having persistent or epithelial defects or recurrent erosion syndromes. These are important things that you must not forget during your preoperative workup. You've already read about the RGP lenses being discontinued for 4 weeks and soft contact lenses being discontinued for 2 weeks prior to any sort of assessment. In systemic history, there are certain things, we will be highlighting them again, which are absolute contraindications, and certain things which are relative contraindications. So you have to understand that an uncontrolled connective tissue disorder or diabetes is absolutely contraindicated, because there can be a risk of stromal melt. Not only should you know what is not allowed, you should also understand why it is not allowed. If you'll be afraid of the why, you will definitely not forget the what. Coming to medication history, because these are young kids, many a times they are on some or the other treatment for acne, meibomian gland issues. They could be on isotretinoin. So if the patient is having a history of isotretinoin or has recurrent history of headaches and is taking certain medications for migraine in the form of sumatriptan, such patients tend to become contraindicated for refractive surgery, as isotretinoin can lead to increased risk of dry eye, blepharitis, and conjunctivitis. If a patient is on some cardiac disorder and has a history of having amiodarone, patient will have very poor wound healing, regression, and dry eye and optic neuropathy can also tend to occur. So keep your eyes and ears open for any such history, and be proactive, and be asking them leading questions to rule out any such problems. Coming to my next slide. Sorry, this is not moving. Yeah. So preoperative workup, as we said, the patient has to be off CLs. We are checking for the manifest refractive spherical equivalent. We tend to insist that the patient should also undergo a cycloplegic refraction in all cases, because you not only need, in cases of hyperopia, you not only need to rule out any latent hypermetropia. In cases of myopia, you also need to find out if the patient is having certain amount of pseudo accommodation and hence a higher myopia than actually needs to be corrected. Patient needs to be checked on automated autopolizer guided keratometries. These days, what gives us a better idea is topography and a tomography on pentacam or Sirius, a pupillometry on pentacam or OpScan, a pachymetry which is occurring from pentacam, OpScan or Sirius, and an AC depth and white to white measurements are all part of your preoperative workup. Now coming to the tomography. So why I'm just taking up the relevant points, because this is a compendium lecture. So we want you to take up the most important points which you've studied so far. So if we see at the pentacam, because this is what you're going to use practically for most of the times, these criterias you should not forget. So the K1 and K2 are representing the flat and steep meridian only in the central 3 millimeter zone. Km is the average K median in the central 3 millimeter. Astigmatism represents K2 minus K1. Q scan is the quality scan, and if that's okay, that means you can use this pentacam for your underscanning. Q value is a measure of the asphericity, and normally it should lie between 0 and -1. Pupil center X coordinate should be less than 200 microns from the apex. So this is the pupil center, and this is the X and Y coordinates that it is showing. Then Peki apex minus the thinnest location should not be more than 10 microns, and the thinnest location difference between the two eyes should not be more than 30 microns. These are important and small features which you will be able to see and identify as you keep on reading these tomographic maps. Thinnest location should be more than 470 microns in a patient who has got an absolutely normal topography, and otherwise the patient should have at least 500 microns of thickness. Kmax, which is showing over here, is a representation of the maximum curvature of the anterior surface. Normally, it should be less than 47.2. And remember that the difference between the two eyes, Kmax, should always be less than 2 diopters, not more than that. And the difference between Kmax and K2 should always be less than 1 diopter. If these criteria are not being met, then you must wait and watch rather than running for surgery, because surgery is a 15 minutes video game. However, it is the rest of the life of the patient which will get affected if the patient tends to develop any kind of ectasia post surgery. Another important thing that you have to consider is the displacement between the thinnest and the apex point, which should be less than 500 microns. And pupillary diameter should always be at least 0.5 millimeter less than the OZ. OZ means the optical zone that we are going to use. So, sorry. Uh, so basically, you need to remember that these corneas, after you have studied the tomographic map, will become at-risk corneas if the sagittal map is showing a Kmax of more than 48.7, K median difference between the two eyes is more than 2, Kmax minus K2 is more than 1, a skewed radial axis of deviation is more than 21 degree, and an inferior superior variation is more than 1.4 diopters. On the pachymetry map, as you saw here, this is the sagittal curvature map, this is the front and back elevation map, and this is the pachymetry map. So on the pachymetry map, the superior inferior difference should be not more than 30 microns. Corneal thickness less than 470 with normal and less than 500 with abnormal topography. Pachyepix to thinnest location more than 10, and Y coordinate thinnest location should not be more than 500 micron. Thinnest location difference between two eyes should not be more than 30 microns. Otherwise, it is an at-risk cornea. If the anterior elevation map is showing at any point a more than 12 micron appearance, and in posterior elevation a more than 17 microns, these corneas are again becoming at risk, and it's important that you keep in mind that such corneas should not be touched immediately. They should be first observed for some time if you feel the patient is healthy enough to proceed for surgery in terms of refractive stability. We also tend to study not only the 4-map refractive, in Pentacam, we also tend to study the Bellin Ambrosio enhanced ectasia map. So, the purpose of this map, as you see here, is not only define the abnormalities but to isolate them by forming a best fit sphere under the abnormality that we are seeing. So here, what are the important criteria that you need to remember on the bad display? On difference map, it should not be more than 5 microns for front elevation and not more than 12 microns for back elevation. The cutoff criteria for ART max, Ambrosio relational thickness, is 339 microns. Thickness profile average progression. So I'll show you here. This is the ART max which you have to look for. This is the corneal thickness spatial profile, which is telling you that from the thinnest location to the outward location, how thicker your cornea is becoming. Okay, so this corneal thickness spatial profile should lie within the curves which have been mentioned here, and so is the case with the percentage thickness increase map. So thickness profile average progression should not be more than 1.1. And in bad D, so this is the final criteria that we need to study. These are the 5 criteria which are mentioned in the lowest most part of the bad D maps. So in the bad D map, more than 1.6, if it is coming out to be, it could be a form fruste keratoconus, and if it is coming out to be 2.6, it is highly suggestive of keratoconus. So rather than progressing for surgery, wait, observe for other types of scans and tests so that you can decide whether this patient is good to go for surgery or not. Based on the tomography and topography maps, there have been various scoring systems which we need to remember. One is the Randleman Ectasia Risk Scoring System. The other that we'll be reading about is the Massachusetts Eye and Ear Infirmary Criteria. The third important criteria, which we very commonly and practically use in our daily life, is the residual stromal bed and the percentage thickness altered or the percentage tissue altered criteria. So in the Randleman criteria, which is one of the oldest criteria we use, important thing for you to remember is that patients, we give risk categories as per the patient. So if the patient is between 0 to 2, it's a low risk case. If it's 3 points, it's a moderate risk case. If it is more than 4 points, then it becomes a high risk case. So remember, we generally do not like to do any kind of refractive surgery where the residual stromal bed is becoming less than 250. These days, the best criteria is to have the residual stromal bed more than 300 microns only. A corneal thickness less than 460 is again a no-no for any kind of refractive procedure. And as far as the manifest refractive spherical equivalent is concerned, most people tend to go maximum up to 10 diopters. Ideal circumstances up to -8 diopters only for refractive surgery. When it comes to Massachusetts eye and ear criteria, eye and ear infirmary criteria, there are again scoring systems which are going to define for us which patient is normal, which is a suspect, where we can think of an early keratoconus and where we can think of advanced keratoconus. So here, inferior superior asymmetry, keratometry of right versus left, and keratometry difference between right and left can also give us various criteria which can help us in understanding whether this patient is a form fruste or an early keratoconus. Most important criteria that we use is residual stromal bed. So residual stromal bed thickness is the thickness that will be left behind once we have removed the corneal tissue after refractive surgery. So whatever is the central corneal thickness minus the flap thickness minus the depth of ablation that we are going to do is going to determine our residual stromal bed thickness. And generally, we must try that this RSBT should not go less than 300 microns. We calculate ablation depth in micrometers by the Munerlin formula, wherein the refractive error is multiplied by the optic zone square, and this is divided by the 3. So they say that RSBT of more than 250 is fine. However, in practical life, we would generally prefer that the RSBT should be more than 300 microns for as much as possible. Another important criteria which has been mentioned by Santiago et al. Is the percentage tissue altered. This percentage tissue altered is calculated on the basis of how much tissue you have changed out of the corneal tissue that you are operating. So the tissue that you are changing is the flap that you have created plus the ablation depth that you have used out of the total corneal thickness. So they generally say that the percentage tissue altered should be less than 40% for any kind of refractive surgery to stay safe for the patient for future. Another important thing is keratometry, which we are going to find post LASIK surgery. So you cannot just go about flattening or steepening the cornea just abruptly. A post LASIK, in a case of myopia, the keratometry measurement is found out by the preoperative keratometry minus 80% of the refractive error. So if a patient has a pre-op keratometry of 42 and a refractive error of 7, so out of 42, we'll be subtracting approximately 5.6 diopters. So we'll be left with just 37 diopters of cornea K readings, which is a flatter cornea. So the safe range in such a scenario is considered to be approximately 34 diopters. Below that, we should avoid any kind of laser-based procedures. If the post-LASIK keratometry in hyperopia, as calculated by pre-op KM plus 100% of the refractive error, we should avoid if it is exceeding more than 53. Coming to important understanding that is topography or tomography sufficient for us to identify a patient as a candidate for refractive surgery? I would like to say that ultrastructural changes tend to precede any alteration in corneal shape. So first there'll be a biochemical process, there'll be a biomechanical instability, then only the corneal shape and aberrations will tend to occur, which will lead to poor visual quality and poor image quality. So we need to detect even the mildest cases of ectasia, and this is the reason why biomechanical instruments have come into play. So most commonly, biomechanical instrument that we use in our clinical practice is the Corvus ST, out of which I'll be just showing you two maps because these can be practical for your exam point of view. That is the biomechanical ARV, or this is a composite map, which is not only having the biomechanical assessment coming from Corvus ST, it is also having the tomographic assessment as coming from Pentacam, and a value from both is integrated into a TBI, or tomographic biomechanical index, which helps us in guiding whether the patient could be having the earliest form of ectasia or earliest form of weakness on the cornea, which can later turn harmful for the patient if we produce a keratoablative procedure on this patient. So as you see here, in this map, you see the cornea is absolutely healthy. The biomechanical index is coming in green zone. The bad D is also within the green zone, and so is the tomographic index. But if you see the other eye, here we are seeing in this eye, there is a keratoconus that we are observing. So not only our corneal biomechanical index is BERSEC, so is our tomographic index. So in early cases, it becomes all the more important that we keep an eye open for CBI and TBI. And especially in suspicious cases where your tomography is confusing you, a Corvus
I'm not audible.
Dr. Kiran?
Navneet,
Yes,
please
sir.
connect. Yeah, ma'am is not audible. No? Please
हाँ
connect.
जी, हाँ जी, हाँ
फिर
जी.
बात करो.
Lakshya sir, ma'am is joining in some time. There was some issue with the electricity at her end. She's just connecting in 2 minutes.
Good. So far, ma'am has covered very nicely which patients to screen. First, history point of view, the expectations of the patient should be real, more than 18 years of age. What are the options available? Then she discussed about pentacam findings, the cutoff values, very nicely presented in one slide. I think it must be a good learning, one page summary for all the postgraduates or all the people listening. In one page, she has summarized beautifully the key readings should be less than 47, how pachymetry, y coordinates, everything she has summarized in one slide. And the last thing which she was covering nicely was Corvis ST, role of Corvis ST in early detection of suspect cases. So Corvis ST gives you a CBI index, which along with D values of pentacam gives us a TBI index, which is tomography biomechanical index. So in suspicious cases, we can opt for Corvis ST to rule out suspect cases. So one nice point which ma'am has covered so far, it is very easy to do surgery, but most difficult part is to screen the patient. Surgical part can be covered in 15 minutes, but screening is the most crucial part.
I think so. Long-term follow-up of all these cases is also very much required, Dr. Lakshya.
Yes,
Yeah, because sometimes we lose the follow-up of all these patients, and after a long time, these patients, when they come up, they might develop sometimes this keratoconus or early ectasias in all these cases. So when we suspect, then I think we should ask them to come for the regular follow-up and regular pentacams or obscan for our records also, and we should get good information from their corneal scans also.
I'm really sorry. There was some glitch with the electricity, so I'm so sorry that I got disconnected. I'll reshare my PPT.
sure, ma'am.
All right. So is it visible again?
Yeah. Okay.
Yes, ma'am.
Okay. So I wanted these kids to see what does a wavefront do. So in a wavefront, basically when we are passing the light into the eye, the light are supposed to, they tend to go inside the eye, and this whole light which is entering into the eye is converted into a 3D map which shows the unique distortions which are present in each of us. So, if these unique distortions are also able to be corrected, then which are also known as higher order aberrations and are responsible for minor variations or minor aberrations that we tend to see in our optical quality, then that is known as a wavefront guided kind of a refractive surgery. So this 3D map is projected onto the eye and then a laser is performed accordingly. So you see, these are the various high order aberrations which you need to know about. These are the lower order aberrations which all of us have. So zero order aberrations are there in everyone. A first order aberration is a sphere or a plus or a minus sphere, and a second order aberration is astigmatism, which are normal and which are easily corrected in a standard LASIK. But then there are higher order aberrations which are given various order according to Zernike scale. You have read about them in the previous lecture. So out of these, some of the most common and important ones are spherical aberrations and also the various type of vertical and horizontal comas. So we'll read about what are the important criteria that are going to help you in guiding through your refractive surgery. So monochromatic aberrations, as we said, zero order, these are the lower order aberrations. 80 to 90% of our aberrations are basically the sphere and the cylinder only. But then 15% of the visual quality is dependent on higher order aberrations, and these are responsible for night vision disturbances, glares, and halos. So if these are present, it becomes important to think of either wavefront optimized or wavefront guided kind of ablation. You'll be understanding about the details of each of these procedures in lectures to come. This is like a primer for you to get an understanding of what and how you are going to take a decision for what kind of procedure a patient is better adapted to. So if you see the main three higher order aberrations which tend to trouble us in our clinical aspect are coma, trefoil, and spherical aberration. So a coma tends to cause a comet tail-like appearance. It creates like a smearing of an image and can be happening after decentered ablations. A vertical coma can occur in a patient who's already having a form-fruit keratoconus or an aborted keratoconus or an incipient keratoconus. So if your aberrations are showing vertical, inverted, or negative vertical coma, it can be a sharp indicator. Now, trefoils are like, a Mercedes-Benz symbol that you tend to see, or a trifoliate clover pattern. Here, the peripheral vision is affected more than central vision. It causes less degradation of image quality than coma. The most important or the most troublesome one that we find is the spherical aberration. You need to understand this is the kind of higher order aberration where light rays from the peripheral corneal lens tend to focus in front of those from the central cornea. So such a patient will have nighttime disturbances, will see more halos, will have decreased contrast sensitivity, and this is the most significant higher order aberration which tends to occur after a corneal ablation. So, preoperative decision making when we are doing, we need to know that a point if a patient has more than zero point 0.4 microns of higher order aberrations, such patients should ideally be undergoing wavefront guided ablations. When we are measuring the aberrations, we also look at the lenticular ablations, that is the ones which are coming not from the cornea but from the lens. These candidates, if there are a lot of lenticular aberrations, they may not be right candidates for cornea based procedures. Intraoperative also, wavefront tends to help us as a guide in wavefront guided ablations. Post-operative, there can be usefulness in terms of objective assessment of the visual quality because that tends to correlate with the visual complaints which the patient is having. And mind you, we had done a very interesting, read up on why some patients are unhappy post surgery. So these patients who are having blur, glare, or halos, sometimes they may be having these aberrations prior to the surgery which were missed, and we never recognized that the patient already had these blur, glare, and halos, and then they were not corrected. But the patient tends to remain unhappy thinking that this is a result of surgery. So it is important that you measure the wave scans of these patients and find out what are the higher order aberrations. Now, this is some charts which I wanted to show you for the topography guided aberrations or topography guided laser. So we use the Allegretto Alcon wave light suit. So it is very important that you take good measurements of the eye, and it should be in consistence of around 0.75 over the treatment area. And these are then sent to the examiner laser. These are important criteria. So if your measurement when you are doing a wavefront optimized, but when do you have to do a topography guided or a wavefront optimized ablation? If a topography is showing a cylinder difference of more than 1.25 between refraction and measured cylinder, if the axis is more than 5-degree difference between measured and your topography axis, in a case where cylinder is more than 2 diopters, if it's more than 10-degree in between refraction axis and measured axis in a cylinder less than 2 diopters, then you should not go for topography guided LASIK, because these days we do tend to do a lot of contour or contour guided LASIK, which are different from wavefront guided LASIK, which you have already read. So in such cases, these criteria you should remember for your exam point of view and also for your daily use. Last but not the least, in the preoperative assessment, don't forget to screen the retina, because posterior segment screening can have absolute contraindications, can have certain interventions which make your patient safer for future. These are myopic patients and can have retinal degenerations, or the patient could be right from day one good to proceed for a refractive surgery. So if the patient already has an RD or a macular disease or a traumatic rupture or a DR, don't do a refractive surgery at all. If the patient has degenerations, lattice degenerations or snail tag degenerations or any holes, you must do a prophylactic barrage laser. Reassess in 2 to 3 weeks. Look for adequate scarring or the take of the laser. If it is not there or there are missed lesions, do a retreatment. Again, wait for 2 to 3 weeks. And if you find the laser reaction to be adequate, then only proceed for refractive surgery. Warning your myopic patient never to forget that he or she is a myope after all, and all through their life they are supposed to undergo periodic posterior segment screening despite the fact that their spectacle number has got corrected. So as we already said, there are certain ocular contraindications. The only reason I kept this slide again is for you to not forget the systemic contraindications. As we already said, a connective tissue disorder or diabetes which is uncontrolled. The most important medicines that you should not be forgetting, isotretinoin and amiodarone. And here, absolute contraindications being a granular stromal dystrophy, which can cause a lot of trouble or to you in the future once you have operated such a patient. I also wanted to highlight the reason that I've kept these tables for you is because I want them to work as your ready reckoners. And I would like to respectfully acknowledge the great work of Dr. Titial sir and his team who have written an excellent book from which these tables have been elucidated. The important thing why I took this particular table is for you to see what are the physical deformities that the patient could be having, because these can cause a difficulty when the patient is lying down in surgery. Another important thing is do not forget the binocular vision assessment and ocular dominance assessment. If you are missing the phoreas or tropias, post-operative, the patient can land up having full blown tropias. And don't forget to see the convergence amplitude. Convergence insufficiency is very, very common in high myopes after surgery. They should be warned about it preoperatively. If the patient is needing to go for presbyopic LASIK or is requiring both corrections, a dominant eye assessment is quintessential for monovision planning. I also wanted to highlight for you the adnexa. If a patient has very deep set eyes, very prominent brows, or small palpebral fissures, your laser cones or your laser keratomes may not be able to set into the eye, and you may find lot of difficulty in docking during the surgery, and there can be a possibility of suction loss. This we have already done. The dystrophies, the uveitis, the limbal vascularizations. Important is dry eye assessment. These days, most of the people are computer professionals and dry eye is extremely common. So the earlier criteria where we used to reject the patient only on the basis of Schirmer's is no more holding true. You need to look at the T-BUT, you need to look at the stainings, you need to look at the mammography. You also need to keep an eye open for the osmolarity and in the MMP9, the criteria of which have been rightfully mentioned. The tear osmolarity of more than 3 to 36 milliosmoles being indicative of very severe dry eye, and such patients should be first optimized for their ocular surface before any sort of laser procedure is performed on them. The purpose of keeping this slide is again as just a ready reckoner. I have already mentioned all these criterias of the keratometry, the residual stromal bed index, the percentage tissue altered, the Corvus ST measurements. So you need to keep these charts in mind as you're preparing for your exams, and you need to keep these charts as ready reckoners for you in later life as well, if you are interested into refractive surgery as your specialty. So choosing the right option will now become dependent on patient profile, expectations, refraction, all the findings that you have found so far. And how will we decide now? So if the RSBT is more than 280, I would prefer 300, a PTA less than 40%, and you are staying between the post-op KM of 34 to 48, you can easily go for a cornea-based procedure. But if these criteria are not being met, it is better to go ahead for a lens-based procedure. How will you proceed then? Cornea-based procedure are either incisional or laser-based. We are no more doing these radial keratotomy procedures. We are mostly doing laser-based procedures starting from PRK, LASIK, LASIK, which can be either robotic, that is femto assisted, or keratome assisted, and the lenticule extraction procedures. The lens based procedures can be a phakic intraocular lens or phakic ICL and a refractive lens exchange. Bioptics means that you can combine both the procedures for the best advantage to the patient. Now, laser-based procedures you have read, they can be either excimer laser only based procedures, a femto and an excimer laser based procedures, or only femto laser procedures. Excimer alone will be surface ablation, that is PRK or LASIK, microkeratome assisted creation. Femtosecond lasers will be femtosecond flap, and femtosecond laser only will be the lenticule extraction, which is in the form of smile or silk or clarity. So refractive correction, again, don't forget this table. The FDA approved ranges are these. For practical purposes, we generally do not prefer to go for surface ablation for more than -6 diopter sphericals, LASIK up to -10, myopia and SMILE also up to -8 to 10 diopters only. And phakic IOLs can be performed for myopia more than -20 diopters as well. However, these phakic intraocular columnar lenses by Star Vision are only up to 20, but the rest of the companies are making customizable intraocular lenses, phakic intraocular lenses as well. So if your patient is less than 40, myopia less than, I would say 10, less than 6, hyperopia, good RSBT, post-operative K criteria being maintained, go for laser. If no, you are using more than 40% of tissue you're altering, AC depth is more than 3 millimeter, and your gonio is good, the surface is good, go for phakic IOLs. In an elderly patient between 45 and 60, suitable for corneal procedures, you can go for presbyopic LASIK. But if there are already lenticular opacities, and mind you, if on wavefront or on eye trace you're finding dysfunctional lens syndromes, then do not go for laser-based procedures or phakic IOL implantations. Instead, think of a refractive lens exchange with a multifocal IOL or an EDOF IOL. So now here also LASIK versus PRK versus SMILE becomes a question mark. What to do now once you have decided, yes, we'll go for LASIK. So PRK becomes good for patients who have mild to moderate myopia or hyperopia, which are into contact sports, need for arm forces, have EBMD or a superficial stromal scar, suspicious topography. But in cases where, contact sports and all, mild dry eye, the good case can also be a SMILE, or silk, that is a lenticule based procedure. Surface ablation is specifically good for flat corneas like less than 41 diopters or very steep corneas also. If the eye is extremely deep set and narrow palpebral apertures are there, in any cases of enhancement ray treatments, we tend to use surface ablation procedures only. Now we'll come to the LASIK machines. I hope we are on time. If you want to stop and ask something, we can stop. Otherwise, I have some more slides to show. Paresh, sir?
We can continue, ma'am. We can continue with the lecture.
All right. So I'll talk about the LASIK machines first. I think it should not take me more than 5-7 minutes. Since I said it's just a primer, I'm just going to show you 1 or 2 slides of each of the things or machines that we tend to use for LASIK. So of course, it can be microkeratome, which you require. Then you need an excimer laser, and we are also using femtosecond laser systems. So a modern microkeratome system is being shown over here. It's got a console. You'll be reading about these lectures. So as I said, this is a primer. You'll be learning about the microkeratome assisted surgeries in your lectures to come. So you have a console, a motor, a keratome head. As you can see, the applanator lenses. These are the vacuum fixation systems, a stop ring, and a foot switch, which we tend to use for movement of this modern microkeratome system. So we have Hansatome, we have Moria, these are very common names, and we have ML7, these are the headpieces that we tend to use for LASIK. Now coming to femtosecond laser. Femtosecond laser was an advancement over the blade LASIK because femtosecond laser uses the microcavitation bubbles at preset depth. A blade LASIK was not able to give us a thickness of less than 110 microns, and that too not with a predictability ratio of plus minus 40 microns. So it becomes much safer to think of a femtosecond laser, which is using a solid state laser with a wavelength of 1053 nanometers. This laser tends to use pulses to cause microcavitation bubbles at a preset depth. These bubbles are composed mainly of water and carbon dioxide, and these bubbles tend to coalesce and form an intrastromal cleavage plane. So this is the mechanism of action of a femtosecond laser. The mechanism is called photo disruption. So lots and lots of laser pulses. So there are 30,000 laser pulses being given in a second. This laser is firing at the rate of 10 to power minus 15 per second. This is the machine which we are most commonly using. This is our intralace or IFS laser. So these are the various parts of the laser system that I've shown. This is the setup. So once we start up the machine has got an auto calibration in the femtosecond system. The machine undergoes initialization, a warm up, which takes around 5 to 7 minutes of time, and an energy wheel initiation. If there is a problem here, you cannot do anything about it. You need to call to the engineers, and there is no other modification which you need to do into the system per se, right? But if you, when it comes to the planning, this is the planning sheet that we tend to use for femtosecond laser. Here you are supposed to make the entries about the patient. You are supposed to write the various requirements that you have of the depth, of the diameter, of what is the energy that you're going to use for cutting the flap. So this is where you are doing the actual planning of your femtosecond laser flap. So this is how the laser tends to pass in the form of small white. You see these are bubbles. So these are cavitation bubbles as the laser emission tends to occur. In a raster pattern, this tends to follow and create a thin flap of the adequate size that we have predetermined. There are various femtosecond laser platforms which are commercially available. The most commonly being used are Intralas, Visumax, and Wavelight, that is by Alcon. Each of these have a different sort of pulse frequency, a duration, the energy that they are using for their pulse, the wavelength on which they are operating. Most commonly, it's 1053 nanometer. The time that they take for creation of their flap, what pattern they are firing the laser in, and how they tend to center their flap on the cornea. Each of these laser systems also have an applanation or a flattening surface through which the laser is passed. So out of these, I would like you to remember that the highest frequency is that with femto LDV, that is the Zemer laser. So what is the purpose of having a high frequency and a low energy? So if there is a high frequency, you will be able to get small dots at a very confluent space. So there is a very high frequency and you will require minimal amount of energy to make these small bubbles, which improves the efficiency of the cleavage or the plane creation when we are using the laser system. So these are the images of the various femtosecond laser systems which are commercially available to us. Coming to excimer laser. Excimer laser is basically the laser which we are going to use for correction of your refractive error in a microkeratome or a femtolaser assisted refractive surgery. It's nothing but an excited dimer of argon and fluoride. So both of these gases are otherwise inert. But when they combine with each other, at that point of time, they tend to produce a photon. They're stripped of a photon, which is when a high energy electricity passes through them. And this photon is further amplified in the laser system and passed on for corneal ablation. The method or the mechanism of action here is not photo disruption. So we read in femtolaser, it is photo disruption. However, in excimer laser, it is photo ablation. So it tends to vaporize the tissue by breaking the intramolecular bonds and generate small unstable particles. The wavelength which we use is the 193 nanometer wavelength. You must remember these wavelengths because these are important for your exams. A short wavelength laser will be a difficult one to produce. A longer wavelength will produce undesirable thermal effects. So this one is the best frequency for the corneal glycosaminoglycans to absorb and the collagen to absorb without producing any collateral damage in the form of thermal damage. So again, I'm repeating, mechanism of action here is non-thermal ablative photo decomposition that this laser tends to use. So as I said, when a high voltage electric discharge is delivered into these gases, excited dimer is produced, a photon of energy is released, and this is absorbed near the corneal surface without causing any, burns or any kind of thermal damage to the surrounding tissue. So this is the laser that we tend to use at one of our centers. This is the Star S4IR by Johnson and Johnson. It is mentioning the type of laser it is. It's a laser diode. So here we have two different cylinders inside this console. One is an argon fluoride cylinder and one is the helium cylinder. The other machine that we are also using is the Alcon Wavelight, which has a single cylinder housing all the three uh, gases. So when we are calibrating this system, now this machine needs to be calibrated every time you are going to start with a laser on a particular day. We have to open the premix of these two gases. Please do it only when you are performing the laser. Otherwise, fluorine, which is otherwise less than 2% of the entire system, is a highly toxic gas for eyes and also for the abdominal linings if inhaled. So a warm up is to be done only and only when you are going to perform the laser, not otherwise. So this machine tends to perform calibration for myopic sphere because that's what you may need to correct, for the cylinder, for the flat, that is the how flat the platform will be created, and also it needs to find out, it also needs to calibrate the centration, the perfect centration of the system. So this kind of plastic plate is used in physics, and I had a video actually, but unfortunately it's not playing on my system. And this is the calibration which tends to happen. The machine tends to, as I said, take these six criterias before, considering the machine to be fit for being used on a human eye. If the machine shows lesser amount of energy, we have to boost the machine for it to be able to, the helium to be able to extract more amount of fluoride or argon and to mix them so that the energy can be boosted for delivery. This is a focimeter which we use when we are using these calibrations. So there are specific uh, dioptric values that the laser should have performed on the plastic plate as I showed. If it is coming to be correct on the focimeter as showed by the laser system machine, then we consider that the machine is truly optimized to be used on the patient, otherwise not. So this is the planning map that we used in Star S4IR. We also, as I showed you earlier, the eye design or the wavefront. Here we are using a wavefront guided procedure. So we have done the assessment from our eye design, and those readings have been added to our system for the final treatment of our patient.
Sorry to interrupt you, Dr. Kiran.
Hanji.
Yeah, there are some few questions online from our for you. So I think
Right. Sir,
Nomi,
I think I will just take one more minute because I just wanted to show these kids
right?
the keratoid lenticule extraction.
Yeah,
That's
it's
it.
just
This is
first,
our ELITA system, the silk or
right.
this is smile and silk. And I've mentioned all the criterias or the details that we need to observe or the energies that we tend to use on our systems. So these kids can always go back to this PPT and, find the relevant information. I think I'm open to questions now, and so are our seniors and our teachers.
Yes.
So yes, sir. Yeah. Am
So
I?
thank you
Should
so
I
much,
stop
ma'am.
sharing?
Yes, ma'am.
Yeah. Okay.
Thank you so much, ma'am, for such an extensive lecture. And so the kids have a few questions. So
Yeah.
there was a slide wherein they were discussing about connective tissue disorders. So there's this question that is ICL safe in connective tissue diseases, if not the corneal-based ablative procedures?
Yes, that will be a safer option for a patient who's undergoing any kind of refractive procedure. If the patient is a very high myop, you can even think about a refractive lens exchange. A phakic ICL can also be a good option. If the patient is having some autoimmune diseases and along with that some attendant uveitis, then I would rather refrain from any kind of corrective procedures. Paresh sir, please, if you would like to add something, you have high experience in ICLs, so I would request you also to answer this question, sir.
Yeah, so basically, all those who are suffering from the connective tissue disorders or autoimmune disorders, I think so, we should refrain from the all this collagen means this cornea-based procedures. So we can go for the ICLs or phakic IOLs. But before that, as I think so, Dr. Kiran was in her presentation, she put a very important point that lens dysfunction disorder, that was a very important point, because sometimes we miss that point. So lenticular dysfunction is a very important point that we should not miss. Sometimes we miss that point, and so after some time, after some period, there will be a development of the cataract, and that will be a suffering of a vision in the patient. So before you go for the ICL, you should rule out that part of a cataract procedures.
So there's this another question. How long to wait after ocular herpes episode has subsided for a refractive surgery?
I think ideal waiting period is at least 1 year. And after that also, uh, I think it is better to give an antiviral cover to the patient and then only take up the patient for such a surgery. If there are still central scars, the patient may not be fit for any kind of femtosecond laser-based procedures. In such cases, PRK or a surface ablation procedure is rather better in comparison to any femtosecond laser assisted procedures, because through a scar the laser will not be able to pass, and you have to keep your eyes closely worked up for any recurrence that is tending to occur. It is better to give a prophylaxis of antivirals. If Dr. Lakshay would like to add something over here.
Please said, ma'am. I think blade-based procedure will also work here.
Yeah.
Microkeratome-based. That is also fine. Laser will not pass, so femto laser is not an option. Either PRK or a microkeratome-based. Yes.
Sometimes you have to evaluate the thickness and the thickness of the opacity, how much thick that opacity is. So you have to take a more deeper cut.
Yes,
And
the location of the opacity also, where it is.
When you are taking a flap thickness, so that you have to take into
But yeah,
account.
post-herpetic, if the patient has really been inactive for more than a year, I think then the patient may be considered for refractive. It comes with a lot of connotations. It comes with a lot of maybes. It comes with a lot of judgment, and refractive surgery appears to be easy, but it is a difficult ball game.
Absolutely.
So where do we suspect higher order abrasions and how to treat them in a refractive surgery patient?
Okay, so higher order aberrations are to be actually suspected in everybody. You don't know who's having and who's not. As I said, we did a whole series where we were seeing that patients who had not been judged for a pre-operative existence for glare, for their day-to-day starbursts or halos, they were presenting with more problems later. And there are retrospective studies which are showing that if we had actually shown to the patient prior to the surgery that you have such problems already, the patient would not be so dissatisfied with the refractive surgery. Now, as I said, if you are calculating the higher order aberrations to be more than 0.4 on your wavefront systems, be it eye trace, be it eye design, then it is essential that you tend to do a wavefront guided refractive surgery. You will be reading about this in your lectures to come, so don't get overwhelmed by this lecture that what is wavefront guided, what is wavefront optimized. All of this you will be learning in due course of time. But for now, you need to understand that if the higher order aberrations are more than 0.4, definitely go for a wavefront guided procedure when you are doing a refractive surgery. Anything that, sir, you would like to add, Paresh sir?
I think so. You are right, Dr. Kiran, in regarding this. Absolutely right. The same point is that similar.
Yeah.
I'm absolutely same thing.
Dr. Navneet?
So, in a patient with larger mesopic pupil, which procedure will be preferred and which will be safer?
Yeah, so I think best procedure, honestly speaking, with a patient who's got a larger mesop, you need to understand that your optical zone that you are going to correct in any kind of refractive surgery should be at least zero point 0.5 more than your mesopic pupil. If so is not the case, the patient will tend to have nighttime disturbances, will tend to have, difficulties that he will land up seeing in most of his daily life. And you need to warn the patient about it. One of the best procedures to go for in such cases is silk or smile. So these procedures, the OZ is around 5.7 to 6 mm, and the transition zone is lesser. And of course, the profile is made in such a way that there is a slight blunting of the peripheries. So your spherical aberrations are reduced. Even in a wavefront optimized LASIK, the side curvatures are reduced in such a way that the spherical aberrations are reduced. So I think if the mesopic pupil is bigger, if it's more than 6 or 7 mm, it's rather better not to go for such kind of surgeries. Okay, and in such cases, using a phakic IOL will be a better option than thinking about a refractive surgery.
So, there's this last question. In a patient with dry eye, how do we proceed with the planning for surgery?
Yeah, so I remember Dr. Navneet and me only having a good
Yeah, we had a
discussion in
discussion.
our clinics that so these days, see, evaporative dry eye is the order of the day in the young. So earlier, dry eye used to be a phenomena of the elderly. Nowadays, with so much of exposure to screens, dry eye is extremely common in the population who wants to come to you for a refractive surgery. So you have to assess, and now we are lucky because there are actual instrumentations. We have an ocular surface analyzer which tends to define for us what kind of dry eye that you are seeing in your clinics. So if the patient is having an evaporative dry eye, you need to first counsel the patient, in terms of his lifestyle management, in terms of his medications, in terms of his improvement of his meibomian gland function, in terms of his treatment of the optimization of the ocular surface. And this you'll only be able to do if you have well calculated the amount of dry eye this patient is having. Even if you need to wait for 1 or 2 months or 2 or 3 months, it is fine. But you should not hurry up in a case of dry eye because later on the patient can tend to have recurrent erosions, persistent epithelial defects, a prolonged dry eye, transient sensitivity to the eye which can become disturbing to him in his or her daily life. So it is very important to optimize the ocular surface and also warn the patient that post-operatively the need for medications for dry eye will be for a prolonged period as compared to normal people.
Okay.
Anything that you'd like to add, sir?
Yeah, one question just I want to ask that as you mentioned in your presentation regarding pregnancy and lactation, so a lot of PCOD treatment female patients are getting, and some estrogen treatment and some progesterone tablets they are
Yes,
taking.
sir.
So, Dr. Kiran, do you take in consideration what type of progesterone or estrogen tablets they are taking, or what type of treatment should be discontinued, or do you consult any gynecologist or obstetricians before that?
Well, yes, so hormone replacement therapy that people tend to take
Mhm.
can, the specific problem with an HRT is that post LASIK, there can be a quick regression in the number. Now,
Yeah,
that is very disturbing to the patient who has undergone a refractive procedure. So, first is we need to consult the gynecologist about the need for the continuation of the HRT and for how long. If so be the case, then the patient needs to be warned that there can be a regression in the number. So, and see, in refractive, I think the most important thing is informing the patient. If the patient is kept in dark, then the patient is definitely going to come back troubled. If he knows what's going to happen, he'll be at rest that, okay, this was supposed to happen, I was pre warned, and I've taken a calculated risk.
that's right.
But whether we need to stop certain specific quantity or quality of drug, I think that is to the call of a gynecologist as to how to go about it.
Sometimes we have to
If you have
control.
some specific experience about this, we would also like to know.
Yes, because sometimes we have to consult a gynecologist and this obstetricians that which because sometimes patients, young female patients, they come with the medications and they put that all that strips and everything in front of us. We don't know that how much amount of that all hormones are in that and what these hormones are causing any changes in the body and how much amount of regression or this all hormones that get it in the body. So
Right.
if we consult this gynecologist and we ask them that uh, which amount of drug it should be discontinued before and at what time for period of time, and then we give them that for this particular period of time you discontinue it and then we proceed for the surgery. That's why.
I
So
have a specific question for Navneet and Dr. Navneet and Dr. Lakshay both. So my question is isotretinoin. So I read this articles recently because one of my patients had come on isotretinoin treatment as being considered a specific contraindication for a refractive surgery in view of the problems that can come with it. Would you like to throw some light on the recent guidelines on isotretinoin use? Because the articles that I read recently were speaking a little differently. So, any guide on that, Dr. Navneet or Dr. Lakshay?
So,
Yeah, Navneet.
as far as I know, isotretinoin it delays healing of the epithelium. So it's better that we ask the patient to either stop the treatment if he wants to get the refractive surgery done, or to delay the surgery till his treatment is finished, because it's a risk. There will be delayed epithelial healing, and the patient might present to us with a persistent epithelial defect or recurrent epithelial erosions.
Right. So, yeah, I mean, what I read was that isotretinoin needs to be stopped for 3 months at least
Yeah.
before the patient can go ahead for a refractive surgery. So, I think we will not consider it as an absolute contraindication anymore, I
But it's
believe.
a relative contraindication, and it's very important to ask such history from patients.
So patient who's coming to you with, obvious acne, it's better to ask such patients
Mhm.
that if they're on any such medication. These are small points which we tend to forget in our day-to-day clinics as well. But they can wreak havoc when it comes to a refractive surgery patient's life and your life also at a later point of time.
just I want to share that we have one full page of this LASIK workup in which our optoms they fill up the form right from the history to the keloid and pregnancy, lactation, hormone treatment, isotretinoin, skin treatment, everything they fill up. Their PG glasses, at what time, opticals means they were made up with the opticals or not, they were made up with the doctors or not, how
Yeah.
how much time before, 6 months or 1 year. Then they do a subjective testing, then final subjective testing, retina consultation, everything. So they fill up the form, and that
Mm.
all fill up the form, they come to the consultation. So the consultant then they check it that all means that is perfectly done or not, and then they ask the patient the Sarmas test, T-BUT, everything is done by the optoms, and
Yes.
that form comes to the consultant. So then means consultant comes to know the condition, systemic condition, ocular condition, everything. So then counseling can be done to the patient perfectly. That what is the condition. That's why.
Absolutely, sir. Most important thing in refractive surgery is judgment. Surgery is easy, judgment is difficult.
So it's very
So,
easy to say that it is very easy to say yes to the patient. It is very
yes,
difficult to say no to the patient.
that's true, sir. But in refractive, the most important thing is to find reasons to say no.
Yeah, true. Very true. Very true.
Thank you, Kiran ma'am, for a
Thank you,
wonderful
Dr.
lecture.
Lakshman.
It was so good.
Thank you, Paresh sir, Navneet, for excellent discussion. Thank you, ma'am. It was very enlightening.
Thank
Navneet,
you.
I think if we don't have any other question, we can close the
Yes,
session.
we are done. We have no more questions. Thank you,
Thank you
Kiran
very
ma'am.
much.
Thank you, Lakshay sir. Thank you, Paresh sir, for
It was
such
And
a
few apologies for the glitch. I'm extremely sorry for the
No,
no,
glitch.
ma'am.
ma'am, no issues, ma'am. Thank you, everyone. Thank you, everyone, for joining us for the lecture.